My name is Benjamin Domb, and this is a presentation and discussion on whether the hip capsule should be repaired in arthroscopic surgery of the hip. When performing hip arthroscopy, a capsulotomy is frequently used for access to the hip joint and for maneuverability of the instruments. This involves an incision of the iliofemoral ligament with or without a T augmentation or extension, and in some cases even an H extension, and this is often performed with a partial capsulectomy. We may think in certain cases we're only shaving a little capsule, but in many cases we're actually excising a large portion of the iliofemoral ligament. If we revert to our basic principles of surgery proposed by Sir William Halsted, closure of the soft tissues was a critical principle. In other words, if you cut it, repair it. We do this with skin, we do this with soft tissues throughout the body. So the burden of proof in hip arthroscopy then is that if you cut the capsule, why wouldn't you repair it? And I think this is the question that we must ask ourselves. The arguments against routine closure may include that it hasn't been observed as a problem, that the idea that the capsule will reform, the possibility of a therapeutic benefit of a capsulotomy, and the concern for stiffness after a repair. On the other hand, the arguments for routine closure include those tenets of surgery of restoration of anatomy, biomechanical evidence for importance of the iliofemoral ligament, the risk of hip dislocation, and at this point, level 2 clinical evidence, which I'll present. And finally, the conceptual question, where else in the body would we cut or excise a ligament and expect it to reform without a repair? So hip instability deserves a word, and I'll say, wait a second, I thought the hip was an inherently stable joint because this has been taught for many decades. However, if we look at our evolution of understanding in the shoulder, it may enlighten us as to our future in the hip. In the 70s, Neer described impingement, and for a good decade or so, everything was diagnosed as impingement until some very smart surgeons observed that some findings did not fit. And that led to the discovery of all the other problems that are well known and treated in the shoulder today. In the hip, on the other hand, 10 years ago, all labral tears were watershed lesions. Then we arrived at the theory of femoroacetabular impingement to explain them. And we're now in this phase where we're diagnosing impingement in a majority of cases of labral tears. But some findings do not fit, and we must seek to explain these other findings. So we've come to the realization that hip instability does indeed exist, but it's different from shoulder instability. Instead of being a dislocation, it's generally a micro instability, which is felt as pain rather than a feeling that the hip is going to come out of socket. So that makes it a little bit difficult to diagnose. Probably this occurs due to a combination of ligamentous laxity and bony anatomy in a majority of cases. The bony anatomy that may contribute includes borderline dysplasia and femoral aneversion, specifically excessive femoral aneversion. So one of the studies that we published that helped establish the idea that microinstability exists looked at the incidence of ligamentum teres tears. And we found that in patients who have a higher level of bony stability, the incidence of ligamentum teres tears is smaller. And conversely, those with less bony stability have a higher incidence of ligamentum teres tears. Likely this is because those with instability are putting more traction on the ligamentum teres and causing it to tear over time. The iliofemoral ligament resists extension and external rotation and acts as a static anterior restraint with full hip extension. So the effects of the capsulotomy then are to cause a loss of restraint to anterior translation and external rotation. Labral repair only restores the normal mechanics when accompanied by capsular closure. And this has been well documented in a number of biomechanical studies by this point. We've also seen that in the extreme of instability, iatrogenic instability due to a capsulotomy may cause a dislocation of the hip. And this is, we've had multiple published cases of dislocations after hip arthroscopy by this point. So, in this article, we proposed that arthroscopic capsulotomy should be treated either with capsular repair in a routine situation or with capsular plication of the hip in cases of those with more laxity or bony instability. This is performed by using side-to-side sutures with or without a plication and inferior shift. If we want a shift, we create an obliquity of the sutures in order to achieve that shift, and then we tie these sutures outside of the capsule. We've looked at the influence of capsular repair versus unrepaired capsulotomy on 2-year outcomes following arthroscopic hip preservation surgery. In this study, we had 403 patients in total, and we prospectively collected the data comparing capsular repair to those treated without a repair. And this was done using 4 patient-reported outcome tools. What we found is that there is a 1.5 times greater probability of a good or excellent outcome for those with a capsular repair versus an unrepaired capsulotomy. And this was true for 3 of our 4 major patient-reported outcome scales. Looking at range of motion, one of our concerns was that there would be stiffness in the group who had a capsular repair. That was not found. There was no significant change in the range of motion between the groups. We've used capsular plication in treatment of those with borderline dysplasia, and these are often young females. In our initial 22-patient series published in the American Journal of Sports Medicine, we used arthroscopic labral repair and capsular plication in all cases for patients who had center edge angle 19 through 25. So this is a borderline group who is generally not considered a candidate for periacetabular osteotomy, and therefore must be treated with capsular plication if we're to achieve outcomes which will be more successful than the historical arthroscopic outcomes in this patient group. We've also published ligamentum teres reconstruction. This is a controversial subject at this point. As of the time of this presentation in 2014, but reconstruction at this point is recommended for traumatic full-thickness tear of the ligamentum teres for those with hip subluxations or overt instability. So the arguments against routine closure to review are: first, it hasn't been seen as a problem. However, biomechanics studies show that it can be a problem. The second was that the capsule will reform. However, there's no evidence in the hip or in any other joint that scar tissue can replicate the biomechanical properties of a ligament. The idea that there's a possibility of a therapeutic benefit of capsulotomy may be true in select cases of stiffness or capsulitis. And lastly, the concern for stiffness after a repair, we found that there is no significant change in range of motion after repair. So back to the arguments for routine closure: the basic tenet of surgery of restoration of anatomy, the biomechanical evidence for the importance of the iliofemoral ligament, the risk of hip dislocation, Level 2 clinical evidence in our cohort comparative study, and lastly, the inherent question: why would we cut or excise a ligament and expect it to reform? Thank you very much.